So welcome to another installment of the CHEPA seminar, everyone. It's my pleasure to introduce to you Dr. Deri Armstrong, who's here because Michelle made the connection. I think it was last year, actually, that the connection was made
earlier than
a while ago. So yeah, we've had this on tap for a while. She flew in from Ottawa this morning, so she's had some time to adjust, I think, to the time difference. She's an associate professor in the Department of Economics at the University of Ottawa. She's also the academic director at a StatsCan local research data center. It's affiliated with Carleton University, if I'm not mistaken, as well. She's president of the Canadian Women's Economists Network, and her research focuses on economic evaluation, applied health, and labor economics. Today she's going to be presenting some of her results from a study on the effectiveness of an outreach facilitation program for cardiovascular care. So,
thank you so much. I'm just realizing, now that I see Byron, that I'm actually no longer the academic director of the Cool RDC. As of March 31st, I guess I should take that off my CV. So thank you, everyone. Thank you, Michelle, for the invitation. I'm a McMaster grad. I did my undergrad here in mathematics back in the early 90s, and it's so nice to be back on your beautiful campus. So I actually ran into Paul last weekend at a conference in Montreal, and he said, "Oh, Catherine, it's so neat that you're going to come to CHEPA and give a talk. You've got a really long title." So it's evaluating the effectiveness of a pragmatic outreach, blah, blah, blah. Very long. So I thought for Paul I would change the title to something a little shorter. What went wrong with our facilitation intervention? So basically what I'm going to be presenting to you today are a lot of results from a very big, what I hope you will believe is a very well-designed, very well-thought-out outreach facilitation intervention. If you're not familiar with outreach facilitation, I'll be talking a bit about that. And what I'm going to show to you is that the goal was to improve the delivery of evidence-based cardiovascular care, and we weren't successful in doing that. So, not to be discouraging, because a lot of times you can learn a lot from cases where things don't go as planned, and I'm hoping that that will be the take-home message of these interventions, that what outreach facilitation can be something really great, ours does not look to have been. Okay, so a brief overview of what I will present to you. I will talk a bit about what outreach facilitation is. I'm not sure how familiar many people around here might be with that. Talk about the actual intervention I was involved with, called the Improved Delivery of Cardiovascular Care, IDoc, through outreach facilitation. Talk a bit about the status of cardiovascular care to convince you that there is room for improvement in the way we deliver cardiovascular care. Give you the estimates of the effectiveness, or lack thereof, in this case, of IDoc, and then spend a lot of time really talking about the lessons learned and the next step and where we're going to go to really try to get something out of this 7-year-long journey. Okay, so I understood that this was a 45-minute talk with questions after, but please feel free to ask any clarification as need be. So outreach facilitation. This is a quality improvement method, okay? It involves an outreach facilitator. So sometimes these are called practice facilitators, practice enhancement assistants, practice coaches. So obviously there's a lot of lingo out there referring to the same thing. These are health professionals, usually nurse practitioners, though not always, usually external to the practice, though not always, who make regular visits to the practice to provide support in change management that targets improvements in the delivery of care. So improvements in the adherence to recommended guidelines, best practices, things of that nature. So what they tend to do is they come in, they work with the practice to identify care goals, identify areas that aren't working so well in the practice, help find strategies, tools, ways to improve, and work with them to support and sustain these changes through multiple visits. Okay? So the focus is on reorganization of the practice. It's not really just about delivering information or specific content knowledge of the work. So really there's a lot of focus on helping to build relationships within the practice, as well as to build relationships between the practice and the more broader health network externally. So while this is probably somewhat obvious, Why don't practices, or why don't doctors provide the care that we would hope that they would? Why don't they, these are best practices, or this is evidence-based medicine, why don't we see them doing exactly that? Well, there's a lot of reasons, right? You think about this, when I teach health economics, I talk about this a lot with my students. We train doctors in their 20s, maybe early 30s, then they practice for 40 years. Tons changes very quickly in medicine, what you should be doing. How do you get doctors to keep up and change their behavior? Hysteresis. No one likes to change. In the literature, the 4 big barriers to change have been found to be time. It takes time to change. Resources. It takes tools. People don't have the tools to change. And they don't always have the incentives to actually change. Okay, so I think, even though it's kind of odd, these barriers are quite obvious, I bring them up because I believe that at least 2 of them are going to be part of the reason we didn't see a change with IDOC, with the intervention that we introduced. And that we're providing the resources, we're providing the tools, but we're not really giving the right incentives, perhaps, and it still takes time. Okay? So just keep these in mind as we go through. So outreach facilitation, I talked briefly about what it is. Facilitators go in, they work with a practice to facilitate change. The thing is, these things, outreach facilitation has really been shown to be very effective. Okay, so if you compare it to other quality improvement techniques or initiatives, didactic education, passive dissemination strategies, audit and feedback, these have been shown to have pretty much no effect, or little effect. As ballpark to be about less than 5% effective, or a change in improvement as a result. But multifaceted interventions, like outreach facilitation, so where there's a lot of things going on at the same time, are shown to be to generate or elicit an over 10% improvement. Okay, so much better. Baskerville has a meta-analysis of these 23 practices, representing over almost 1,400 primary care practices, and find that doctors are 3 times as likely to implement evidence-based guidelines when supported by an outreach facilitator.
So
yeah, sorry.
This is for cardiovascular disease only?
No, for facilitation. So there's, the facilitation trials, and I didn't really explain this, sorry, they go back to the 80s, early 80s, but they tend to be very targeted. Yeah, so sometimes they're about stroke, diabetes, asthma. Okay, so this is just looking at overall effective change for an intervention. Okay, but there's a lot of gaps that we still don't know about facilitation. In particular, what's the optimal intensity of the intervention? How many times do you have to send a nurse practitioner or your outreach facilitator into the practice to generate meaningful change? The meta-analysis clearly shows that the more intensive the intervention, the more successful it is. But of course, there's a big cost. The more you send in facilitators, this is increasing the cost, and you can also well imagine that as a physician, if I'm having to commit to, seeing a facilitator every 3 weeks for a year, that takes a lot of time. That might discourage me from even wanting to participate, right? So you've got to find the right balance for your intensity, the sustainability. Not really known. We all know you go to the gym in January, everyone's changing. You're quick to sign up for a gym membership and go, but come March, the place is empty, right? So although these facilitation research studies have found that you can elicit change, how long does it last? That's not really known. And what are the characteristics of the practice associated with greater change? How best to structure the intervention? In a lot of ways, this facilitation is a bit of a black box. We know stuff happens, we know we get these results, but what exactly of this multifaceted intervention is really what's generating change? So, that was the introduction to outreach facilitation. Our facilitation trial, this IDOC, pertained to or was aimed at improving cardiovascular care. So, I think most people in this room I don't have to spend a lot of time on this, I hope. Cardiovascular disease is the leading cause of death and disability in Canada. And it's been shown that preventative care or primary care can be a very effective way at preventing and managing cardiovascular disease. and the fact that 95% of Canadian adults with chronic conditions have a family physician. We hopefully believe that they trust their family physicians. Primary care really is uniquely positioned to improve care. So if you think about these doctors a few years ago, or many years ago now, this started back in mid-2000s, about 10 years ago, really embarking on this venture, this is really an area where, wow, if we can improve cardiovascular care, we could generate some really meaningful health results. Okay, so IDOC, I've given the title already a couple of times, was led by PIs, two PIs, Doctors Claire, Lydia, and Bill Hogg. These are GPs/researchers from the Ottawa region. A whole bunch of us co-Is. We're very broad in terms of our specialties. I'm the economist, but I don't know how these names mean anything to you, but we've got epidemiologists and other physicians and more qualitative people on the team. But in addition to this team, we've had over, I'm trying to count quickly here, I would say 7 or 8 program coordinators, managers, 4 outreach facilitators, 6 chart abstractors, and a whole slew of other research associates and summer students doing work on this project. So this is a really big initiative. Okay, and there's a website there if you're interested, especially for students, because I happen to be perusing this website, which I don't think I've looked at in a long time. And they have a page, and I'm sure it's a still valid request or welcome. They're saying that if there are students out there, research students that are interested in the data or this project, they can contact the PIs, Claire or Bill, and maybe get involved, and maybe, I'm sure they'd be very happy to find a way to work with you to, if you could think of something cool to do with this data. Because a lot of time and energy has been put into generating this data. I'm going to talk about all the different aspects of it, so maybe you can think of something fun to do with it. So, a quick thank you to the many, many funders of this intervention. So what was IDOC? IDOC, as I said sort of briefly to Michelle's question, previous facilitation interventions were very targeted. They were targeted as a small disease. They were small interventions, very intensive, focused at a few practices, but there were no real big trials. So the idea of IDOC was to be a pragmatic trial. So we're changing a bunch of things at the same time. We're going not one disease specific, we're going multi-disease, cardiovascular disease, and we're going big. We're not using one outreach facilitator facilitating 10 practices. We have 83 practices in this study in the Champlain Health region. So this is the Ottawa and rural areas. So 1.2 million population, 16,000 square kilometer area. So a very big area. And the intervention was rolled out between 2007 and 2012. I think the goal should be clear. The goal was to assist family practices in improving their delivery of evidence-based cardiovascular care. And who are we targeting? Patients with or at risk of cardiovascular disease. Fine.
What fraction of all practices in the area is the 83?
Okay, I'll talk about that explicitly, but if my memory serves me correct, we approached all family practices. So there were 500, we thought there'd be 533, we had to exclude walk-in clinics, etc. So of the 400 and, I'm terrible with numbers, 400 and blah blah, we have 83 participating. And in fact, if there's time, I could tell you about another paper that we're doing where we're looking at the representativeness. So because we approached all practices, we're going to link later on to some administrative health data, and so we can actually compare participating practices, so our 83 with non-participating, but usually when you do this comparison, you're just comparing very general sort of demographic characteristics. Are they male, female led, the number of years, things that you can observe easily, types of practices, but here we're actually looking at the quality of care that's being provided. Okay, so yeah, no, it's not a random, but it's a good chunk. Okay.
And why 5 years? Because
why is the intervention 5 years?
Yeah.
It's a bit more of a longer explanation. Can you wait?
Okay.
It's a stepped wedge design, so we're rolling it out in 3 steps to be able to identify the effect. We'll come back to that if that's not clear to you. Okay. So the intervention itself is pretty standard in terms of what outreach facilitation tends to do. the external health professional, in this case, I'm going to read this because it's quite impressive, I think, were nurse practitioners with master's degrees in clinical and management experience, were used as our outreach facilitators. They underwent a 7-week intensive training course focused on quality improvement, change management techniques, the chronic care model, as well as tools for cardiovascular care, including this is a picture of the cover of this report. So this was a report generated by 45 local experts in cardiovascular care, summarizing the latest evidence-based strategies for CVD prevention and management, and includes a lot of, it includes a lot of links to community-based programs and services. So really trying to foster the best use of resources between making sure that practices are aware of the other resources that are available external to the practice itself. Okay, so these are super well-trained facilitators. They go in first to the practice and we do an audit and feedback. Okay, so previous to the meeting, we send in chart abstractors into the practice. We'll talk about this in more detail again. Take 66 charts of patients with or at high risk of cardiovascular disease, and then we present to the practices how they do on a number of dimensions with respect to cardiovascular care, relative to the benchmark, this is what you should be doing, and relative to how everyone else in the Champlain Health Region is doing. Okay? Then showing them this information and highlighting where they're doing very well and where they're not doing so well, they work with the practices to determine what goals they want to work on. So what aspect of cardiovascular care do you as a group want to work on? And then they provide the decision aids, the flow sheets, all the tools and resources that they need to bring about this change. Okay? And then they work with them on a regular basis over a 2-year intervention. Now, in some way this could be my last, I could almost end here. So the intention of the intervention was to have 13 visits in the first year, an intensive year, and then a scaled down level of intensity in the second year, 4 to 6 visits. Okay? So this was the intention, but what was realized was far less than that. So we had, on average, only 6.6 visits in the first year, so half the intended dose, and only 32 practices had 8 or more visits. Okay? And only 2 actually had 11, so no one even got to the full 13. Okay? So even though it's hard to think of a way to actually show that this is what made things go wrong, but this is certainly suggested. Now you're probably thinking, well, what the hell happened? How come you couldn't, why is the dose so low? And this really comes down to the pragmatic nature of the trial. Okay, so these are volunteers, and we'll talk about this when we talk about recruitment. Practices were asked to participate, to volunteer their time for this intervention. Okay? They were not getting paid for this. They got some, I forget the name of it, those credits that you need to stay in good standing with the College of Physician Services, college.
CME.
CME, thank you. I was going to say CDR, that's not even close. CME credits. So they got some of those, but I guess those aren't so hard to come by, or maybe they are. But that was the incentive. So if I'm just going to finish this up, I'll go back. So I think what was happening was that the outreach facilitator tried to reach these physicians and say, okay, let's schedule a next meeting, great, or at one meeting, okay, here's the date for our next meeting, yeah, it comes up. All right, so don't forget I'm coming on Thursday. Oh, shoot, Thursday doesn't work. We're really, really busy. It's flu season. We can't close our clinic for an hour and a half to meet with you. How about next week? And it just gets delayed and delayed. It was just the real nature of trying to get a group of doctors in a practice to find a time to all get together and meet with a nurse practitioner. It's just not that easy. And then it must have just been these delays, these compounded delays, and this is sort of coming back to this time and the incentive, perhaps, problem.
I think you probably mentioned this. Where did the 13 come from? Is this based on guidelines, or why is 13 the magic number?
Oh, no. This was the intention. This is what we set out to do. So this must have been based on, I wasn't part of that initial discussion, but Bill and Claire, who ran the study, have been involved with other facilitation trials, and I think this was understood to be what a good facilitation I could look into that to get back to it. I don't think it's a magic number. I don't think there's ever been proven that, I mean, no one's done cardiovascular care in general, so it's hard to say that a number for
So
another.
realize the 6 visits in year 1 is not good in terms of, okay, I'll just wait for the rest of the presentation.
Well, we don't know what went wrong, but we know we didn't get the dosage we intended.
Yeah, but is that a bad thing? If you didn't get, I don't know, because I'm just wondering, where did 13 come from?
Yeah.
Why is that the number that you guys were intending? And if you didn't get it, is 6.6 bad in terms of whatever?
Yeah, so, I mean, that absolutely comes down to where we're stuck right now, is that we're finding out it didn't work, and then it becomes, wow, this is a really great opportunity to learn from why it didn't work. Can we figure out what went wrong? Was it the dosage? Was it these other factors that we're going to talk about later? If you can help me figure out how to disentangle these different channels, it'd be great. Because maybe, you know, it is expensive to send these into, you're paying for someone to travel to a practice, prepare, present. I mean, if you're taking the physician's time, you know, it's a costly intervention.
Yeah.
Okay, so you're right. It's a good thing to figure out. It's not obvious that 13 is better than 6.6. We know it didn't work.
The real cost of the intervention isn't your facilitator's time that costs. It's the opportunity cost of the doctors.
Yeah, it depends how you want to measure it. What is the cost to a program funding facilitators? It's the cost of facilitation. The overall societal cost would include the physician's time.
Right, and clearly that's the problem.
Yes. I'm going to say yes because that's how I'm understanding this to be. I'm sort of ruining all our slides for later now, but what we're going through right now are I don't know how many of you have done a lot of qualitative analysis, but all the facilitators transcribed minutes and notes from their meetings, and all the journals that they've kept are being put into in vivo, and we're really trying to understand what happened. Okay, so I mean, there's some understanding, having talked to facilitators, that they just couldn't coordinate, and it was a time issue. But you know, can we actually back it out more rigorously and convincingly? We'll have to wait.
Why didn't you pay them?
Why didn't we?
Yeah. Because presumably they're losing income if they have to shut down for an hour.
Yeah.
If you pay them, they might be more willing to actually sit down.
Yeah. So in the discussion of our paper, we talk about in BC they have this. I'm going to get the paper right here because I knew I'd mess this up. There's so this intervention in BC. That's the wrong page. There it is. Where they actually pay doctors to do a kind of, let's talk about this here. So, to implement practice support program which offers time-based payment to physicians and their medical office assistants who participate in 4 learning modules which are very similar in this spirit. And they have 70% of all doctors participating in this because they're paying. There's a similar thing in New Zealand in the same spirit, but the doctors actually have to pay to get this service. No one uses it. So you're right, and maybe that's what it's coming down to. Maybe you need to pay, and maybe that's, you know, when I said time and incentives, maybe we just need to compensate people for their time. I mean, I think the spirit of this, when you listen to Claire and Bill talk, you know, this is a voluntary program, and if you were going to roll this out in the province, say, either you think about paying doctors for their time, or this is what you run into. So yes, very good, yeah. I think going back wouldn't have been nice if we paid them, but then, yeah.
That's only half the opportunity cost, right? You're paying the doctors. What about the patients who aren't getting visits?
Now it's getting very expensive.
No, but if you're really thinking about opportunity costs, we're in a shortage situation nominally for primary care physicians. So the real cost of the program is the cost to the patients who aren't having visits, as well as the doctors who don't have income.
Yeah, but now they're getting better care.
Yeah.
Right?
Some of them will be getting better care. The ones who have cardiovascular disease, the others just won't be getting care.
Yeah.
But, you know, if we're right in that you only need 6 visits a year for an hour, you're right. I mean, you can...
The opportunity cost is large, right?
Opportunity cost is large. Absolutely. So, I talked about and I was going to get rid of half the slide, but I didn't. So, here is picture of what the practices were given at the end, but the first half, so what they got at audit feedback time is this first half right here. Okay, and so what it looks like, and maybe it's a little hard to see, but batteries died on all the pointers by the end of the semester at Ottawa. I don't know if that really doesn't happen here. So you see the audit and feedback, the outreach facilitators came in with a 30 to 60 minute PowerPoint presentation where they talked about each condition separately and highlighted these processes of cares for hypertension, dyslipidemia, et cetera, and they show you how your practice is doing based on the chart audits versus all IDOC practices, and they of course talk about the recommended, which would be 100%, and then they color code it. They say, look, thumbs up, this is where you're doing great, and future improvement, the politically correct way to say this is where you need help. Okay, that's what it looked like. We'll come back to the second panel in a second. Okay, so recruitment, this is what Byron was asking about earlier. So this was intended to be big, right? This regional approach. So all primary care models, except walk-in clinics, were invited to participate. And like I said, in this big Champlain Health region. So we identified 533 practices, of which only we deemed 434 to be eligible. Okay, so we had to exclude, like I said, walk-in clinics. Some of them didn't actually exist that we thought should have, so this is full disclosure of what was found. And we excluded any practices where the lead physician was expecting to retire, was planning to retire in the next few years during when the intervention would be carried out. Okay, because if they disappear, then all of a sudden you can't get back into the practice, collect data, and then it's gone. Okay, so we ended up with 83 that participated, 83 practices representing 191 physicians. Okay? The fact that no practices withdrew after the start of the intervention is considered by our PIs to be a really good sign in the sense that physicians do actually want, even if they're not willing to put in the time, they like the idea of the intervention, they like outreach facilitation, and they do value what they were being offered. Okay? So the data we collected, so what I'm going to show you is chart audit data at multiple points in time. Yes?
In terms of the recruitment success, did you notice whether those who agreed to be part of the study tended to be maybe more group practices than solo physicians, more of the family health teams who decided to be part of it versus not being part of the family health team?
Yeah, and I decided not to bring that paper that I was speaking a bit with Byron, where we're comparing the participating and non-participating practices. They were very different in a lot of the ways you'd expect. A lot more females, a lot more collaborative practices versus fee-for-service. Younger physicians were more likely to participate, but we were actually also able to look at quality of care, right, using this administrative data. And it is the higher performing practices too, based on these criteria, that did opt to participate. But when you run regressions and try to control for these observable characteristics, these observable patient level, more practice level and physician level, it explains away most of it. So it is sort of, if you can control for a lot of the observables, you can explain a lot of the differences. Okay, so the data that we use for the main outcomes paper is chart audit data. So it's going to be repeated chart audits from the same group of patients. So we audited 66 patients per practice, losing about 12% to follow up over the 5 years. So either patients moved away or they died. And given the nature of the study, we were looking for patients over 40 with at least one of the following conditions. The first chunk are the cardiovascular diseases, coronary artery disease. You can read it faster than I can say it. And then, so these are the people with cardiovascular disease. The last one are people at risk of cardiovascular disease. So they had to have 3 or more of 4 risk factors. So they had to be males over 45 or females over 55. Hypertension, dyslipidemia, or smokers. So those are the 4. You needed 3 of those 4. Then you became at risk, even if you didn't have one of those conditions. Okay? And the data that was collected was information on diagnostic and screening, drug prescription information, clinical test results, and counseling and referral programs. Okay, so we collected quite a broad spectrum of information. And based on this, we published a paper looking at the status of cardiovascular care, prevention and care, I suppose, in the health region. And I'll just tell you a bit about that because it really does highlight that there's plenty of room for improvement. Okay, so the baseline data was collected for 4,837 patients. 47% of all these patients were the diabetes patients. Okay, so it's not equally divided across the cardiovascular diseases. 21% were smokers, 77% had high blood pressure, and 83% had dyslipidemia. Okay, and while if you look at processes of care, so this is chart, when we audited the chart audits, we were looking at indicators over the past calendar year. In terms of how many of them had a blood pressure checked in the past year, that was very high. Lipid profile was recommended, was very high. But where things didn't look so good was how many people were asked to have their waist circumference recorded. Okay, so this is the very, okay. In terms of smoking, for smokers, the sample of smokers, those that were recommended smoking cessation counseling wasn't bad, but those that were referred to an actual smoking cessation program was very low. And of the diabetes patients, those who had the recommended 2 HbA1c measurements done was about half. Okay, so coding is happy, really bad, medium bad. That's where things stood there. But where things looked really bad was in terms of clinical markers. Okay, so of the patients with hypertension, those at the target blood pressure rate was less than 50%. Low LDL, well, basically, I'm not a doctor. I don't know how many of you are, but this is bad. Doctors say. Okay, so to summarize the findings from that paper, the treatment for blood pressure and cholesterol were high. However, less than half of patients are at the target levels. Adherence to preventative recommendations for smoking and waistline measurements is poor. And HbA1 screening for patients with diabetes is poor. Okay, so the conclusion of this paper, which has been cited quite a bit already, is that there are significant improvements, opportunities for improvement. Okay, so you think, great, enter back to this IDOC. Hopefully we'll be able to elicit some change. Okay. Oh, you were asking about family health teams. So this was, I threw this in because this was to me a very interesting cut of the data. So maybe if there's students that can think of, now hopefully you get a picture of the data that we have and maybe something you might want to look at. But if you compare these process of care indicators by type of practice, the family health teams are coming out as the who you want to have your doctor to be, where you want to go for your care. Okay. Significant, some pretty interesting and important differences across the groups. And this is not controlling for other factors, mind you. This is just okay. So the audit and feedback stage, there's a lot of qualitative data being captured in this intervention. The chart abstraction, along with the feedback, helped us to visualize more directly the strengths and weaknesses of our practice. The main problem was documentation in the EMR of smoking status and previous therapy offered to help quit smoking. Okay. So this is picked out of a whole bunch. Basically, people really do value being able to see how they're doing relative to everybody else. That was well found. And then this is more just for your information, so you have a full picture of what IDOC was. At the end of at the very end of the intervention, we went back and showed everybody, sent them a little booklet that were really well done, a few pager, which included, remember, this is what you look like at baseline, and here's how you're doing now at your sustainability year, at the end of the second year of the intervention. Okay, with more thumbs up, congratulations over the 2 years of IDOC. This is what you've accomplished, and here's some resources for future improvement. Okay, so really again trying to help foster good change. And comments on the final report. The various flow sheets for hypertension and diabetes have simplified my work. At a glance, I could see how my patients are responding to the care and management. Patients have also noticed a positive change in how their problems are being addressed efficiently, managed in a prompt way. Another comment. The main impact of my participation in this study has been to make me more aware of my need to ensure patients at risk of CVD are followed at appropriate intervals and how easy these individuals can be lost to follow-up. Okay? So maybe this is me just trying to say, look, it looks like it was going to work. Okay, so why did this intervention take so long? Well, it started in 07, 08, where we went in and got all the baseline data, but we divided the actual intervention into 3 steps. So different groups of practices got them at different points in time. Okay, so step 1 practices had their intensive year in 08, 09, sustainability year the following year. Step 2 practices started everything a year later, and likewise with step 3 practices. So for the economists in this room, and I know there are plenty, this is basically a diff and diff type identification strategy. In the medical world, this is called a stepped wedge design. And basically, you know, if it's not obvious, the idea is that if you didn't have these other 2 steps and all you did was compare outcomes from baseline to after, if there were any secular trends, if there were any underlying trends in quality of care over time, you wouldn't be able to separate what is really the intervention versus what else was going on at the same time. Having practices start late allows you to control for what would have been, so have a control group or a counterfactual to compare with. Okay, and so you can keep identifying the effect of this year's intervention with what was going on in step 3. So yeah.
No, sorry, you touched the screen.
I know it's a touch screen. All right, enough of that. So, I just want to be very clear. This is not a purely randomized controlled trial in the following sense. So this is the Champlain-Lynn, and it was divided up into 9 regions. I got to get the word right. Okay.
Thanks.
Yeah. Sorry.
Question on the previous slide. So practices knew, for instance, those who were in step 2 and 3, they knew from the very beginning that they would start later, or?
I don't think they were told exactly when they'd be starting.
Okay. But they knew they were part of the
Yeah. They
were
applied.
Yes, we agree. And okay.
Yeah. And then I think it was more on a need-to-know basis, is my understanding. It's okay? Okay. So the Lynn was divided up into 9 regions and then separated by west, center, and east. Okay, so there's 3 regions in each one. So 1, 2, and 9 are the west. Center ones are there in the east. Okay? And then I know this sounds like it was unnecessarily complicated, but I think you'll see why this was done the following way. Then 1 region from west, center, and east was allocated to step 1, so regions 4, 8, and 9. Then randomly 2, 7, and 5 were assigned to step 2, and the balance were step 3. Okay? So it's these regions that are randomly assigned to step, not the actual practices. Okay? So we do need to take into consideration any correlation or clustering of outcomes and differences across regions in our design. Okay? So why is step wedge design? It minimizes the practical, logistical, and financial constraints. Okay, so if you look at a region that's 16,000 square kilometers, if you've got practices all over the place that you're responsible for facilitating, it's unreasonable and financially prohibitive to send people all over this large area. So at least it's allowing, at a point in time, one facilitator can work in this region, et cetera. It allows for this identification to allow for causal interpretation of the effectiveness by allowing to control for secular trends that we discussed, and it ensures that all practices actually get offered the intervention. Okay, so what was our primary outcome? Talk a little faster. Was a measure of quality of care, so a composite score reflecting adherence to recommended care guidelines. So it's basically, it is the number of recommended care maneuvers performed divided by the number that the patient was eligible for. So the outcome is at a patient level, even though the intervention is at the practice level. Okay? And these are the 8 recommended maneuvers that were chosen for our composite score. Okay? So just to be clear, the chart abstractors, the facilitators, the practices, no one was aware about exactly what we were looking at. This is a subset of that longer list of what was in their audit and feedback. Okay? It's a bit simplified, and this was a pretty long discussion about what is the best way to measure quality of care, but it was felt that, this was, if we're going to elicit change at the system level, that we should see measurable changes in these outcomes. So I'll show you some baseline numbers to show you basically how these looked beforehand. Okay, so I don't know how medically inclined people are, but it includes some measurements, some actual levels, so kidney function, glycemic levels, and then the ones that apply only to people who are supposed to be on medication, which is basically everyone for lipid-controlling drugs. Are they on lipid-controlling drugs? And if you're a smoker, were you referred to a smoking cessation program? Okay, so is the outcome, so it's a composite score. That's clear? Okay, so the baseline characteristics by step. So the point of this chart, this is on 2 pages, is to show you, this is not a randomized controlled trial, so we do expect some differences across steps. But it's important to see how big they are and think about what this means. And on the bottom line here is going to be the composite score. Okay? So we could see that, for example, in step 1, 81% of the practices were fee-for-service, whereas none of them, and none were this capitation interdisciplinary. But, sorry, I should have just stuck with fee-for-service. 81% the first step, only 41% thereafter. Rurality was quite different across steps. There was a lot more rural practices in the step 3. Okay, composite score about 64%. Okay, so it's not like we were starting at a very, very high level and gave us no room for improvement. Looks like there's quite a bit of room from 64 to 100. But in terms of composite score, there didn't look to be very much difference across steps. In terms of differences at the provider level or the patient level, again, these are what we were able to, these are the information we collected on a chart audit. So you could also see we knew the number of the percentage of the practice that's female, their average number of years since graduation. The patient level, we know how many cardiovascular related conditions they have. Okay? So on average, they have more than one CVD problem, and in terms of risk factors, on average, it's about 3. Okay, so these are pretty sick patients already, so already you're thinking that their treatment and their dealing with them is already quite complicated. There you go. Okay. And this, I bring this up because you could think that maybe this is sort of the problem. I mean, you're already dealing with a very sick, complicated case. Is this really the group of patients where you think you could see, am I going to, this person's already very sick. Am I going to worry about waistline measurement for these people?
I would not interpret that.
No.
With the average of 3 risk factors and 1.2 actual
Out of 4
conditions. But I would not necessarily, once you take in 40 plus, this is reality.
That's what, I'm 40 plus.
Well, I'm considerably past that, so I have a different perspective, perhaps.
Okay, so maybe that's not.
So I don't,
Okay, so that was my interpretation.
And
yeah.
do you have a health status measure?
Do we have a health status measure? No.
On the patients?
This is what we have. No.
That
This is chart auditing.
Okay, so.
This is the measure.
You actually don't know their health-related quality of life, the patients.
Nothing like that, no.
Right, and I think if you go to the CCHS and pull out the sample of the age demographic, you will find that folks with these characteristics often have pretty good-looking health-related quality of life.
Okay. Thank you. No,
But aren't these people all selected to be ones who do have some cardiovascular related?
Yeah, so this is conditioning on having at least one cardiovascular rated
So
condition.
1.18 isn't a whole lot more than
Than one.
Which
No, I guess you're right. No, you're right. No, you're right. But it's definitely more than one. It's not like I just have, on average, people have more than just one problem.
Yeah, but nobody my age has one kind of condition, which is actually not true factually, but
Okay, so maybe these aren't as sick as I. Okay, so maybe they're not that sick. So in my head, I was imagining that these are sick patients, and I'm not, the last thing, we don't have to do a waistline measure. This person has enough problems to deal with as it is, but point well taken, maybe they're not as.
Well, I mean, the waist measure, that literature, that, BMI predicts less accurately than the waist-hip ratio, right? And if you're actually in the clinic, it's really not too hard for them to get a tape measure out and do those 2 measurements. And it's actually more useful information than the BMI, which they actually have in their records.
I wonder if that changed from the guidelines, and is that new, these two waist to hip thing?
Oh,
versus
that's
not?
like at least 10 years old.
Well, this is, don't forget, this is already based on stuff from like 2006.
Yeah,
right?
but I mean, that's, you know,
Yeah.
that's pretty, whether it's.
They should have known.
They should know. On the other hand, I think it'd be hard to find, it'd be interesting to find. My guess is there's a number of large healthcare systems have BMI but don't have the waist hip ratio.
Got it. Fair enough, thank you. You know, it is hard, you try to be a scientist and you're looking at the data for what it is and you just, you look so hard to try to understand and, thank you. Okay, so estimating the effect of IDOC. So how do we, I assume there'd be a blackboard here this time. So, estimating the effect of IDOC on quality of care. So if you can imagine I also didn't think there'd be as many economists in the room. So quality of care is your left-hand side variable. We're trying to explain this composite score. And just think of it as a diff and diff, okay? We're going to have fixed effects for time, treatment phase, and geographic location, east, center, west. We have random effects for the cluster, so for the region, also works the same with fixed effects for the region, the unit of randomization. This is a fancy way to say that we account for correlation, or the standard errors are clustered for by patient to take account of the fact that we have repeated observations for the same patient over time. And the key variable of interest is this 3-level categorical variable. What is the effect on quality of care from being in the intensive phase relative to the baseline phase and from being in the sustainability year relative to the baseline year, right? So what we were hoping, or what we invested all this money into this intervention thinking, is that we would see, relative to baseline, quality of care increasing in intensive year and hopefully even bigger in the sustainability year. Okay? Yeah. I'm going to show you, I have the full regression results if you're interested. I'll just show you the coefficients for the treatment dummies. For 3 different models, an unadjusted model, right? If this was a real randomized controlled trial, you wouldn't really expect to need anything beyond an unadjusted model, but because this is not a pure RCT, we're going to control first for patient characteristics that we can, so not the full health, but what we can observe, so those variables we looked at, and then additionally control for the practice level characteristics that we have. Okay?
So,
yeah.
This is more detailed than necessary at this point, but why are you clustering on the patient? Why not the practice? The intervention is at the level of the practice.
I think there was, well, yeah, I don't know.
I mean, the real reason for that is because then you only have 83 degrees of freedom. And your standard errors would be giant. But the truth is you're trying to change doctors' behavior, not patients' behavior.
Yeah,
But the outcome
I
measure
think
is not,
It
it's
doesn't
not
matter.
unilaterally
It doesn't-
physician behavior.
But you cluster the standard errors at the level of the intervention,
Yeah, no, I
not
appreciate
at
it.
the level of the,
Yeah.
not the unit of
But
analysis.
on the other hand, the observations of the patients are not independent.
That's the whole point. That's what I'm saying.
Yeah.
No, but they're not independent. I mean, there's two,
No,
So you
but
wanted
there's two
to-
layers of
Yeah,
dependence
but if
here.
you, but if
One
you-
is within person, and the
Yeah,
other
yeah.
is the within
but you're
practice.
allowing for arbitrary correlations across patients if you're doing it at the level of the practice. So one encompasses the other.
I think you need both.
Well, in principle, you
In
can do
some
both.
purest sense, you need both.
No, but the higher level encompasses the lower level, right? If you're clustering at a high level, you're allowing for arbitrary correlations at lower levels. So one
Yeah.
encompasses
So,
the other.
I mean, the one thing that would be good, but we can't do with this kind of data, is allocate patients to doctors, right, within a practice. Because you'd also think that within a practice you'd want to control for which doctor, but the data was collected at the practice level and they're not attributed to a specific doctor. We've tried so many things. I mean, this is this is what was specified at the onset, and we had to do exactly, in this medical world, what.
I understand.
Yes, so I'm just trying to understand, like, was there a reason why it would, was it clustered somewhere else, and did we try it? I can't imagine we didn't try it. I don't believe the results to be I'm gonna go back and report back, because I know exactly what you're saying. It's,
The only reason you would do both is if you saw patients go across practices, then you'd want to do both. As long as the patients stay within one practice, if you cluster at the higher level, it encompasses any lower level clustering.
it does?
Yeah. Your standard errors are going to get so big,
Yeah.
you're going to end up with
0.
anyway. But, you have
But we don't have
errors.
0.
Okay.
Can I show you what we have?
Mhm.
We have negative statistically significant effects. Not only did the IDOC intervention not increase,
So you're harming people.
Oh, you're reducing the quality of care, you're not actually gonna.
okay, no, okay, but no. I'm very quick to say this is not a meaningful decline. Okay, in terms, okay, so let's just look at this for a second, and then we'll, so yeah, so we have statistically significant negative effects, so decreases in quality of care. Unadjusted, it does go down a bit when we control for patient level factors, but adjusting for provider level factors don't seem to change much. So there was a predetermined MCID, minimally clinically important difference, so that's the smallest improvement that would justify a change in management. So it suggests improving this, and it was predetermined that it would be 8%. So a 4% change, what we're finding here, is not clinically significant. Okay? I can show you, if, I'm not going to bore you with the coefficients, but if you look here, this is what's happening. This is the unadjusted mean. Things aren't changing very much. Okay, statistically they are. There is a decline after, a bit of an upward trend, and then it looks to flatten out, but things aren't changing that much. So I don't want you to think that this was terribly, or I'm hoping not terribly bad for patients, but certainly that's what the numbers are telling us. Yeah?
Were you able to look at any of the specific maneuvers rather than the overall quality score? Did you have the power to look at any specific maneuvers to see whether there's any change in those per se rather
No,
than the
and
lower score?
that's sort of where things are going, and they're very careful about, it wasn't powered to do that, so there's only 66 patients per practice, and then if you divide it up into, maybe with diabetes we could. I mean, what we did is we tried to say, okay, well, what if we looked only at the subsample of practices that got a fuller dose? No one got the full dose, but they got 8 or more, so those 32 practices, not much changes, okay?
So you did have enough power, because I've been wondering this the entire time, if you even had enough power to, so there was sufficient power with 66 per clinic, so there's 83, to pick up a modest effect.
Well, yeah, we're picking up a negative.
But the thing, like,
Yeah.
there's so Arthur's point on cluster, so no patients were going to physicians that were not within your practice.
Well, we wouldn't have seen them. We're chart auditing. If you, a patient, I see you and I chart audit you here, and if I can't find you again in the data, you're not in the data. If you've moved to another clinic or another doctor, you're not in our, we don't pick you up again. We had to see you at baseline where you were. And we lost 11.8% of the sample.
And you don't know what's happening with specialist visits, so.
No, but I can show you where.
So when you say
We're going to look at administrative data that's going to allow us to look at that. But that was not collected in the, so this is chart of abstract data. So this, what was collected was what was collected.
So when you say you lost patients, I'm actually less worried about the patients you lose than the patients who stay with that doctor and are also simultaneously seeing a different doctor, which is, as we know, ubiquitous in Ontario.
Not you.
Sorry?
Not you, though.
Not me, well, I have to any doctors.
Okay.
Don't trust them. They might discover that I'm sick or something. But no, it's that you're only seeing part of the treatment that each patient is receiving, or from a high
That's very
percentage, or for some percentage of the patients. So you said later you have access to administrative data. Can you see the patients or just the practices and the
Patients.
administrative data? So then you can actually see whether they went and saw other physicians or not in this period. And then you
We
can
haven't,
say,
but wow, we can. No, it's
I mean, you can do
yeah.
some really, really nice work with that.
Okay, so, am I done with it? Okay. Yeah, so let me tell you about the administrative data, because I'm basically out of time already. Minimally significant, or so what happened? Okay, I think we've talked a lot about these. You know, was it that we had insufficient dose? We don't know what the, there's no golden number here. Did we focus on something too broad? We went in there, no one knew what we were trying to do. Like we were going to try to look at this improvement in composite score, yet we showed them all this stuff. Facilitators could improve, the practices could work on whatever they wanted. Was it the composite score? What exactly is it picking up? Was it just too general? More directed help. Oh yes. So this was, if you're leaving up the choice of what you're going to work on to the practices, maybe you shouldn't leave it totally up to the practices. You should go in and say, okay, here's what, maybe that's totally against the spirit of outreach facilitation, but we're not going to pick up what they're choosing to work on. And it could be that more time is required to implement and change. If we're only seeing them 6 times a year on average, right, the first year, well, maybe it took a few meetings before they even decided or converged on what to work on. How do you expect to see that effect right away? If, you introduce these things and before you actually see meaningful effects, maybe it takes some time. Maybe this is too short a time frame. Okay, so to quote Albert Einstein, not everything that can be counted counts, and not everything that counts can be counted. Maybe things worked, and we just can't see it in what we're looking at. So the next steps, and I think I've talked about this to some extent, we're going through the qualitative information to try to back out, can we see what practices we're really wanting to work on and identify their goals and use that to see if that helps us understand what happened. Looked at what were the actual improvement activities that were undertaken, and very quickly we also got, is it okay if I take 2 minutes? Super quick, I don't have more to go. We got access to some administrative data because we said, well, what can we see in the administrative data? We weren't thinking of anything quite as complicated as this. Were they getting good care, but just not from this doctor? I'm totally out of order here. Obviously, there are advantages of going to administrative data, right? We're looking at outcomes you couldn't see in chart abstract data, so visits to specialists, visits, hospital admissions for cardiovascular care. We can see it not just for the 66 patients that we had chart abstraction done for, but for the entire practice and for a longer group of time. We can go back in time and get more of a secular trend. We can look further in time to see if changes today in preventative care actually translate into measurable outcomes later. There are limitations, okay? So identifying this cleanly with the data is not clear, and we would lose the CHCs. Okay, so I talked about the different outcomes that we've asked to look at. Right now we only have the hospital admissions for CVD done, but we were planning to look at the number of specialist care visits, and I'm going to have to think a bit more about what you're suggesting. How it's done, basically we give the doctor's ID numbers to ISIS. Okay, they create a patient roster. Okay, so if you're a roster doctor, we have the list of all your patients. If you're not, we virtually roster your patients. Okay, so this is a validated algorithm at ISIS to associate all patients to doctors. Then we have to identify the group at risk or with cardiovascular disease, not done as clearly. And we get information about the patients, and then we can look at the patient's outcomes. Okay, so you can see that there's a lot of, it's not perfect. Okay, I talked about that already. And unfortunately, the rules at ISIS are they have to really vet things before they release it. So let me tell you what we found. So for hospitalizations for cardiovascular disease, we're finding negative point estimates, and in this case, negative is good, that IDOC seems to have decreased hospitalizations for cardiovascular disease, but the standard errors are really big. So we can't, it's indistinguishable for 0. So again, it's looking like maybe it didn't work. So again, the take-home message. So while the results certainly question the feasibility of scaling up these outreach facilitation interventions, it's not at all that outreach facilitation doesn't work clearly. It works in many contexts. It would seem to us, though we can't show it definitively, that the dose is critical. And maybe thinking about the breadth of what the intervention is looking at, the focus on disease-specific, specific diseases versus this more whole approach would be important. And the last thing I have here, for those interested, is so the Champlain Health Region, which paid for a lot of this intervention and is very much invested in this whole research project, has recently come out with a new outreach, basically facilitation program, inviting people, do you need help? You know, would you like to use the EMR to its full potential? Are you running as fast as you can, but the office still runs late every day? You know, we're here to help. We're going to send someone in to help you. Okay, so they're not discouraged. And thank you all for your, I'm happy to answer more questions, but I know that people probably have to get back to where they were. Yeah?
I just wondered if you thought about trying a different subset of things to create your score. Because the one thing that jumps out at me that may be causing you a bit of a problem would be your smoking variables.
And that it's not captured properly?
Well, not that it's not captured properly, but maybe it's just the referral to smoking program is just one of those things that's just not responsive to intervention. So it may not be so much that the doctor's not trying to encourage people to quit smoking, but if people don't want to quit, they're not going to quit. So he might say, you know, are you still smoking? You want to think about it, and they say no. Well, he's not going to document that. You don't know that conversation ever took place, and so you've got a variable that's a little resistant.
So, yeah, so it's
And maybe is causing you some issues. I know that smoking cessation is resistant to financial incentives, so I just wonder if it might be a problem.
I mean, I didn't do the sensitivity analysis on this main outcomes paper myself, but I know they played around with a few things, although, you know, what's in the paper that is being completed right now is the measure, as we said from the onset, that we would look at. You know, it is something to think about, that of all the measurement, of all the parts of the quality of care, that's probably the one measured with the most error, and, you know, what if we exclude that one, do we see meaningful change? Yeah. I mean, it only applies to it was what, 20% of the sample were smokers, so it's not, but no, it's a good point and certainly worth.
It's just a follow-up
Yeah.
on what was just said. I mean, I know about Bill Hawk's some earlier work with practice facilitation, and there was a paper was published back in the early 90s that showed the difference between what the chart audit found and what patients said happened. And there was a discrepancy between, you know, the charting behavior of the physician, and then when you actually ask patients what they experienced in the appointment, there was a difference. And smoking was one of those areas that wasn't being well documented. Asking people about their smoking behavior. So,
I mean, now with EMRs, you think that the documentation, like I imagine in the 90s there wasn't as much.
no, yeah. But
EMR,
there was a
but-
difference between what patients would self-report.
Yeah. So I'm just wondering if that result would even be different now, but,
So, yeah.
okay. I will ask them about that question. Thank you. You had a question?
Very quick,
And then-
yeah, very
Very quick, because we would get in trouble if we don't show up at a certain time
If you
over
think
there.
about adjusting for the practice facilitators, some might be better than others. Because you have 5, right?
That's it.
4.
You said 5?
I don't know. Four.
So is your email?
Yeah, no, yes.
Is your email on the poster? Because I'm just wondering if people have other follow-up points that they can just flood your inbox with questions. Because obviously this is a hot topic right now. But we're going to get in trouble and not get let into the university club if we don't leave now. So,
If you want to follow up the discussion, then you can also join us for lunch.
yes, absolutely. Thank you.
Thank you very much.
No, I